We are so excited to present today on a domestic violence advocacy workshop and talking about what healthcare professionals need to know. This is so important because, as a lot of you guys probably realize, when you're in medical school and residency, you oftentimes don't get dedicated training about understanding what is intimate partner violence, what should we do for patients, and how should we be better advocates for these types of individuals. So I'm very excited to be presenting today with my co-hosts. I'm Janae Rasmussen. I'm currently a fourth year orthopedic surgery resident in Modesto, California. I'm joined here by Alyssa, who is a third year medical student at Toro College of Osteopathic Medicine, as well as Laura, who's a third year medical student at SUNY Upstate Medical University in New York. And then also by Rachel, who is a fourth year medical student applying to orthopedics this cycle, who goes to Edward Via College of Osteopathic Medicine. Today's workshop, we're going to be talking about domestic violence, about what are some of the orthopedic manifestations of domestic violence, as well as what are our responsibilities as healthcare professionals, what are some screening tools we can utilize, what are some of the interventions that we can use, and then close off with a summary. And the acronym for this entire talk is SEEN. SEEN stands for S for being serious, taking disclosures of abuse seriously, to educate, really making sure that as healthcare professionals, we're working on a broadening awareness about the various forms of intimate partner violence and educating our colleagues to engage within others within the healthcare field and in our communities, and then to notice red flags and warning signs.
Hi, everyone. I'm glad that we get the chance to talk on such an important subject. According to the National Coalition Against Domestic Violence, within the United States alone, there's an estimated 10 million people every year that are abused by an intimate partner. We'll be using the word IPV to replace intimate partner violence throughout this presentation. So, when we think about domestic violence, often we gravitate towards physical violence, but domestic violence encompasses other factors, including emotional, economic, psychological, and technological. So the statistics range between different organizations, but anywhere between 1 to 4 and 1 to 5 women are affected by domestic violence, and anywhere between 1 to 5 and 1 to 9 men are affected by intimate partner violence. Now, these statistics change depending on whether we're talking about sex, gender, and that can kind of further split this data. But what we wanted to kind of establish here is that domestic violence is not just physical violence. So our purpose here is to shed light on the role that healthcare providers have by using data that's provided by survivors themselves. So this study done here was done on female survivors in 2006, which identified intimate partner violence as the most common cause of non-fatal injury to women. We need to recognize that the first place of contact for some of these survivors is the emergency department setting or follow-ups in the orthopedic clinics. So here we have the PRAISE study, which was done in 2010. Basically a cross-sectional study or a study done at one point in time at orthopedic fracture clinics across Canada, the United States, Denmark, the Netherlands, and India. They were able to establish that 1 in 6 patients disclosed a history of IPV in the past year, with 1 in 3 in their lifetime. Women in the United States and Canada reported an increased risk of abuse in their lifetime when compared to those in Denmark and the Netherlands. Now, this here is a literature review done by JBJS, a very well-known established orthopedic journal, that established that 1 in 50 women presenting to an orthopedic clinic with an injury have been injured from IPV. So the most common injuries in these settings tend to be head and neck injuries, but following that are musculoskeletal injuries, which include sprains, fractures, and things like foot injuries. So this highlights the importance of orthopedic surgeons to actively screen for the signs of abuse in these settings, because some survivors might not disclose this information for fear of retaliation from their partner. So lastly, this review here kind of provides a way for providers to identify and intervene on behalf of the survivors. So screening for domestic violence can occur in the primary care setting here in the United States via the screening guidelines provided by the United States Preventative Services Task Forces, and this is done in women of reproductive age. But knowing that 1 in 3 women who present to orthopedic fracture clinics have experienced IPV within the past year should open this pathway of screening within orthopedics.
Thank you so much, Laura, for highlighting some of those important statistics that we oftentimes don't learn about until we get education specifically on IPV. So, in terms of orthopedics, it's important to recognize that a lot of patients are not going to feel comfortable and they might oftentimes feel embarrassed with sharing the truth about what might happen, especially if they had a fall and now they have an ankle sprain. Very rarely is a patient going to feel comfortable to say, I was affected by intimate partner violence. Most of the time, the story is going to be a little bit convoluted or a little vague. And so, one of the things that we can do is we can work on trying to talk to the patient alone, especially if there is a partner or someone else at the bedside, is trying to create that distance because you never know if that person may be affecting them, even if they seem very affectionate. And so it's important that we try to find opportunities to have one-on-one conversations and making sure that we're not just fixated on the one injury or the one thing that stands out and assessing in their medical history, are there recurrent fractures or other injuries? Recognizing that screening is typically underutilized, especially in the orthopedic field and even in orthopedic trauma, we oftentimes don't have standardized screening for things such as intimate partner violence. And therefore, intimate partner violence is oftentimes very underreported. And so the ultimate goal is we want to figure out ways that we can implement screening and referring pathways through orthopedic clinics and through the emergency room and inpatient settings to help provide additional safe spaces for domestic violence survivors that we interact with. And so, with that, our responsibilities is one, recognizing signs. Oftentimes, as discussed, these injuries may be physical and are oftentimes unexplained. However, as Laura highlighted, intimate partner violence is not just physical. Oftentimes, there's an aspect of financial coercion or emotional abuse, and those factors oftentimes can manifest in mental health diagnoses. For example, severe anxiety and that can sometimes manifest with physical symptoms such as IBS or frequent abdominal pain, which is oftentimes highlighted in the literature, is that sometimes individuals with severe anxiety or intimate partner violence or fear of going home tend to utilize the emergency department more and oftentimes don't have these clear-cut symptoms. Sometimes it's just, I have this horrible abdominal pain and constipation, and nothing I do seems to help, or these complaints of having, I have a horrible headache and it keeps recurring. And so recognizing that sometimes things that might seem straightforward on the surface may actually just be symptoms of underlying manifestations of intimate partner violence. So it's important for us to remain curious. And with that, we can utilize modalities such as screening, especially in the primary care setting in orthopedics, to help us potentially weed out where are some of these patients that might be experiencing intimate partner violence that we might have otherwise missed. And we'll talk about some of those validated screening tools in the next few slides. From our perspective, it's also important that we document carefully, not just any sort of physical injuries with physical exams, but if there's patient statements or if there's any sort of photos that you get patients permission to share. For example, some of the electronic medical health records like Epic, you can take photos of things like bruising or markings. And once again, recognizing that while we oftentimes will fixate, especially in orthopedics, on the physical injuries, there's oftentimes more damage that is from the non-physical injuries. And we want to do everything we can to ensure safety. So this is where having an idea of what are some of the referral resources, whether it is through the many nonprofit organizations or online resources, or things within your own community or hospital setting that can help with ensuring that patient knows here are some tools that you can utilize. And then importantly, we want to make sure that we know what are reporting tools or things that we need to do within different hospital systems. So there are really good tools for child protective services or suspicions of elder abuse. However, when it comes to intimate partner violence, there typically is not as good of resources or at least a lot of understanding about what to do. And something that's really important is if you have a patient that does disclose to you that they are experiencing intimate partner violence, the first thing you should do is not make a call to the police. You want to help give that patient control. You want to help them feel empowered. And that is really you then saying, here are your options. What would you like to do? And explaining to them their different options. Because what can happen is if you all of a sudden take this authoritative stance and say, well, I have to now get the police involved, now all of a sudden that patient might close off and not want to open up more because now they're afraid. Now they feel even less empowered and less in control over their situation. So again, it's important that we are aware of what we can do for reporting, but also remembering that at the end of the day, our job is to ensure their safety and make sure that we're educating them about resources and we're not trying to force someone in a direction that they don't currently feel comfortable.
All right, hi everyone. I'm Rachel. Thank y'all for the time and space for us to have this event and conversation. So I'm going to talk about screening tools. Like any other screening tool in medicine, it's usually a list or a questionnaire of sorts of all any kind of questions that we want to know about a certain topic or condition. And when it comes to conversations like depression, domestic violence, sometimes structured questions like that could feel disingenuous, as if we're not actually looking at the patient and asking the questions, we're reading it off of a piece of paper or from our computers. And while that could be perceived that way, I want to remind everyone and bring awareness to the fact that these questions are validated and evidence based because they encapsulate everything we want to know from a healthcare perspective about this topic. A lot of times, I don't know if you've navigated a conversation about domestic violence or someone finally opening up to you about domestic violence, but that conversation is very, very hard to navigate as the supportive person in that conversation. And it can easily derail into the end of the conversation. You go home, you lay in bed that night and think, I should have asked this question. We should have talked about this. I can't believe I missed asking something like this. And that's exactly what the screening tools are designed to help, you know, alleviate. So, with that in mind, HITS is the first one. It stands for Hurt, Insult, Threaten, Scream. It's a quick 4-item questionnaire validated in primary care, but in any other setting, truly, to help uncover abuse. Each item is scored from 1 to 5, and a higher total score suggests a greater likelihood of abuse. And so, as you can see, these are what we go through with domestic violence patients if the opportunity arises. This is public knowledge. This is Googleable. So you can go ahead and review and refresh yourself if this is something that you may encounter one day. If you don't know how to navigate these questions, these are also here to aid you. WAST, or Women Abuse Screening Tool, is a brief validated questionnaire designed to specifically detect abuse within intimate relationships, not just physical violence, but also encapsulates emotional and psychological abuse as well. It starts with 2 simple questions about tension and conflict in the relationship, and if those responses suggest concern, the tool continues with 6 more detailed questions that probe specific abusive behaviors. Each question is scored and helps clinicians assess whether abuse is likely. RADAR is an easy to remember framework. It stands for routinely screen every patient regardless of their demographics or appearance. Ask directly, kindly, and without judgment. Document your findings very carefully, assess the patient's immediate safety, and review options with the patient and make referrals to the appropriate support services. It's powerful because it reminds us that asking questions about abuse is not just a one-off question. And so crucial to these screening tools is the skill of asking non-judgmental questions. It means we use open-ended neutral language. Instead of asking, why don't you just leave your partner? We might say, can you tell me about your relationship? Or are there times when you feel afraid at home? This normalizes the discussion by explaining that questions about relationships are a routine part of care because abuse is unfortunately common, as Laura has already, gone into. Primary, secondary, tertiary prevention. Prevention of domestic violence involves 3 key stages. Primary prevention occurs when violence happens before the violence happens, and it focuses on promoting healthy relationships, especially in our adolescent population, and providing anticipatory guidance in pediatric and adolescent medicine. Secondary emphasizes early identification, screen patients routinely, and build safe, trusting environments. Tertiary aims to reduce the long-term harm by connecting survivors with community resources, shelters, counseling, hotlines, to name a few. Developing a safety plan in collaboration with the patient is an essential part of the tertiary care. Partnering with social workers and advocates also makes these interventions more effective and more efficient.
Hi everyone, my name is Alyssa. Thank you for allowing us time to discuss such an important topic today. So I'll be discussing an approach that we use in healthcare called the CUES intervention, standing for C for confidentiality, U and E for universal education, and S for support. So starting out with confidentiality. So as healthcare providers and just people in general, creating a safe space for your patient or whoever you may be discussing this information with is crucial. You want to allow yourself to be an outlet for someone, and just taking the time to create that energy for your patient so they can be receptive towards that. So really emphasizing that to the patient that this is a confidential conversation, so there are no worries about any further disclosure. So universal education is something that we want to highlight to emphasize the importance of giving resources to everyone, no matter who you're talking to, whether you think they may be in a situation or not, everyone should have these resources just to have knowledge and to be able to educate themselves and others in these situations. And support is something that's crucial, having empathy towards people. Um, there's no guarantee that someone may come forward in this situation and forwardly say, "This is my situation," not anticipating that and rather just taking a back seat and letting them listen to what you have to offer, being empathetic and compassionate towards people, um, is something that we really try to do when dealing with patients in this demographic. So here we just wanted to take some time to allow you guys to scan this QR code with any handouts and pamphlets, and further share that. And then we also have some phone numbers that are of use for anyone that you may think may need this. So just leaving this up for a minute for you guys to have.
All right, and those QR codes we have on the right side of the screen here, which are free resources that should be able to help, and we hope that you'll share with others. So some final thoughts. Domestic violence can affect anyone, regardless of age, gender, sexual orientation, socioeconomic status. Even if you're a physician, you can still be a survivor of domestic violence. Importantly, healthcare professionals, we don't often get very good education and training in how do we have conversations and how do we be good advocates for intimate partner violence. And so taking the initiative to learn these skills on your own, if you don't already have training, and recognizing that you can be a critical key liaison, an educator, an advocate for your patients, and that it's really our responsibility to learn these skills, especially if we aren't learning it through medical school, residency, or as an attending. Recognizing that people are oftentimes afraid or embarrassed to ask for help. And so, us creating a safe space, us knowing how to use screening tools and how to make patients feel comfortable to open up to us, that can make a huge impact in that person potentially disclosing what might be happening, and potentially that being a turning point in their trajectory for that relationship and their overall quality of life. And of course, sometimes people aren't necessarily ready to get help. Just because someone is in a situation that to you or I might seem like an obvious red flag, it is important that we remain non-judgmental. Our job is not to tell a patient, this is what you need to do. And instead, our role is to help educate them about here are your options. When someone is a survivor of intimate partner violence, typically it is not due to a lack of love. It is due to that person putting so much force of control that that person no longer has a sense of control. And so the more that we can help empower them, give them tools, give them the feeling that they are in control over what steps are taken next, is more likely to help open up those conversations. And you might be that first person to identify signs of intimate partner violence. And so, regardless of if you're an orthopedic surgeon or you're in primary care, whatever your subspecialty, you might be that person that plays that pivotal role in helping someone get awareness and education that they might not be in a healthy relationship, or here are tools that they can potentially utilize to help them. And remember that domestic violence, it's not just physical. Especially in orthopedics, we tend to have the tendency to focus on the physical manifestations. What does the fracture look like? Or what is their recovery going to look like? But in reality, most of the time, intimate partner violence is more about the psychological effects and oftentimes the mental health considerations, such as depression, anxiety, social isolation. All of those things typically go hand in hand. And so while we might only initially see the x-rays when we're consulted, it's important to always keep that curiosity about what else might be underlying. And so with that, I hope the main takeaway that you all get is that it is our responsibility as individuals and as healthcare professionals and as an overall healthcare community to learn these skills, to have those uncomfortable conversations, and to recognize that we might be that person that sees what is going on and helps that patient directly, positively change their life. And it's really important that we come from a place of not being judgmental and remaining curious, as opposed to putting patient perceptions into different bags. Here are some of our resources. And with that, we wanted to thank everyone for tuning into this. I know that this was short and sweet, but we wanted to just give a little taste of how important this topic is. And some of the resources that we highlighted can really help with continuing with this education. And I hope all of you will share this information, some of the handouts that are free online with colleagues, fellow medical student classmates, because all of us have a responsibility to help be an advocate and educator for individuals experiencing intimate partner violence. Thank you so much for joining us.